Mr. Staunton, I join Senator Harkin in thanking you and your family for what you are, for, as he said, turning your anguish into such constructive work on behalf of other people. Dr. Perlin, Senator Burr asked a little while ago about whether there was a difference in the rate of infections when you go into a hospital and when you go into an ambulatory surgery center. You're in charge of a lot of hospitals, you're in charge of a lot of outpatient centers. Do you see a difference between the hospitals and the outpatient centers that you manage?
Well, first, I'd be remiss, Senator Alexander, if I didn't thank you for your terrific leadership in Tennessee, what this country has to experience. We get the privilege of working with Senator Alexander across our great state, and thank you for that.
Thank you.
The ambulatory surgical center environment and the hospital environment are slightly different. Hospitals do concentrate the risk of patients who might be carrying other infections, but good infection control practices have to be used in both environments. The truth is that our national data need to improve to determine what the rates are, but what we do know is that among patients who have surgery in hospitals, and admittedly the data are only good for there, is that sadly between 1 in 10 and 1 in 3 acquire infection, and up to 5% of those are surgical site infections. Now, toward understanding and preventing those, we're actually following up on the same study team that did reduce MRSA, working with CDC and others to actually implement a variety of strategies to try to make that rate of what we believe to be largely avoidable infections zero. So I would encourage first our better national surveillance of infection rates in those environments. Two, there are likely similar problems in terms of infection prevention between both. Either way, the rates are too high and the goal has to be zero, and we have, I think, a national need to ask CDC to help us get better data on that.
Mr. Chiani has said that the goal should be by 2020 to prevent these infections. I have brought up in hearings here the importance of accountability. We're going through that with dealing with the tragedy in fungal meningitis and compounding pharmacies, and a big part of which I think came because of confusion about who's in charge, who's on the flagpole, who's responsible for this pharmacy or that pharmacy, and we're about to work that out. I use the example of Hyman Rickover, the admiral, who told his submarine captains in the 50s, if you're in charge of the ship and you're in charge of the reactor, and if there's a problem with the reactor, your career is over, and we've never had a death from a reactor on a Navy submarine. Now, you've had a lot of experience both in government with the VA and with now privately managed hospitals. And when we're dealing with lots of different institutions, we're always tempted here in Washington to say, for example, President Obama did the other day, University of Tennessee is doing a good job of graduating its students in 4 years, and someone will say, well, if they did that, let's apply it to all 6,000 universities. The president didn't say that, but we're tempted to do that. But we know it doesn't work when we just take a good idea and make everybody do it. Based on your experience, what can we do to fit into the strategy to reach Mr. Chiani's goal by 2020 without making it more difficult for hospitals and managers to reach that goal? And how can we put somebody on the flagpole? How can we make it clear who's accountable for reaching that goal by 2020 so that we don't have infections in hospitals when we go to get well and instead get sick?
First, let me start by saying that our immediate goal has to be no infections now, no preventable harm now. We've talked about a number of strategies that don't have to wait. Hand hygiene, members of this committee have already alluded to. The rates are really insufficient. Needs to be high reliability. And we need to hold ourselves accountable for dealing with high reliability type behaviors, which would mean hand hygiene each and every patient encounter, before and after each and every patient encounter. We can accelerate through a learning health system, the ability to bring together not only large sets of data, as was mentioned, but to compare interventions and find out what works best. requires us not only, or gives us not only the ability to create new evidence, but also to apply it. That's why in HCI we've applied the reduced MRSA universal decolonization across all of our intensive care units. It's why the CDC and others are building that into the infection management or infection control compendium right now. This is really remarkable change. That study was a 44% reduction on top of every other best practice. And when we have good science, we need to make sure that we apply this science consistently and rigorously. And performance measures are actually a very forceful mechanism of creating transparency and thus accountability. And so we actually like the ability not only to have that transparency, but to identify where good performance is occurring.
Thank you, Dr. Perlin. Thank you, Senator Alexander.